So, and in the ICU, the same thing. It's the same concept. I mean, what you have to keep in mind is that ENI is a measure of the autonomous nervous system. It's a measure of the autonomous nervous system. And the value of energy is the one that is going to tell me how powerful my autonomous nervous system is, and the value of ENI is telling me which is the percentage of that amount in the body that I'm expending on parasympathetic, which means anti-inflammation, um, no surgical stress, if you want. So we can use it obviously in the ICU, we can use it in the OR, we can use it in transport. Why not? We can use it everywhere, just taking in our mind this thing, no, in palliative care, etc. We are going to be able to titrate the analgesics as we have been doing in the anesthesia department in the OR in mechanical ventilated patients. All mechanical ventilated patients need to be sedated, and especially they need to be analgetized in order to provoke the synchronization of the ventilator to the patient, in order to provoke that the ventilation drive of the patient will be decreased and the patient will synchronize with the ventilator. The ventilation, it's a harmful process. Some people may tell you that it doesn't hurt, but having a tube in the throat, it hurts. And inflating your lungs when you are trying to restrict it, it hurts. Okay? So, yeah, we have some studies already performed in the ICU correlating some scales of pain with ENI with very good results. The BPS scale, for instance, is one scale that is helping the patients, helping the doctors to detect the amount of nociception that they have. And ENI is very well correlated to that. So ENI, it's a very useful tool to assess that. We have other kind of publications just making a stimulation on the patient, and you can see that before stimulation the ENI was high, obviously because it's sedated. When I make the stimulation, it goes down and it returns back when the stimulation stops. Or exactly the same results in this other study. So in a way, it's validated exactly the same way, the same thing that with the Funke study. This is an example of the usefulness of ENI in the ICU. We need to keep in mind that in anesthesia, the patient is under the drugs for just 1 hour and a half, 3 hours, 5 hours maximum. But in the ICU, they are under these drugs for days, even months. So what they call sedation, which for us means a softer procedure, in fact, is a much more stronger procedure than just an anesthesia. Okay, because 24 hours. I mean, during anesthesia, you will never be under anesthesia for 24 hours, and in ICU, you will be for sure more than 24 hours. So the risk of oversedation is huge, and the amount of the problems that they have due to these drugs is huge. So oversedation needs to be avoided. This is the reason why probably you have heard about procedures that they just stop completely the sedation once a day in order to awake them up and putting them to sleep. But imagine the suffering of awaking with all that amount of vias and tubes, etc., on the patient. So the best way is to titrate to maintain the levels that we want instead of provoking over sedation, which, by the way, sedation in ICU, it's exactly the same thing that anesthesia, as I said. So it's sedative drugs plus analgesic drugs plus sometimes neuromuscular blockade drugs. So here you can say that we have a quite nice ENI value on the 70 range, and that when we are gonna prone him, the movement provoke a stress and activation of the sympathetic, and it went down. So inflammation release, etc. So they saw it and they give it a bolus of analgesia that drives the patient to a parasympathetic side, so anti-inflammation, and it was just going down as long as the bolus was ending, and then it comes the bath again and it went down again, and when they add another bolus, then, or end of the bath in this case, then it went up again. So you can see what is happening exactly in your patient, that maybe with scales, especially if you are deep sedated, you will not be able to see. But the second part is not only titrating, and that it will always have a benefit on winning, obviously, etc. But the second part is if ENI can be a prognosis mortality tool. As we said, we are heart rate variability, and there is a lot of publications, as these two, for instance, that are saying that a low total power, so low energy, and high HF-LF ratio, so high HF-Nu, so high ENI, is linked to mortality. So patients who has a very low amount of autonomous nervous system, and that amount of autonomous nervous system is just parasympathetic, it means that your reserves has been expended. You don't have any more hormones, sympathetic hormones, to react to stressors, and you're about to die. These are other articles that are talking about exactly the same thing, but in this case in septic shock. In septic patients, at the beginning, you will have a high reactivity of the sympathetic trying to fight that infection. So probably you will have low ENI values around 50, 45, very difficult to increase. This is a good thing, and probably we don't need to stop that, because we need to help the body to react to that. We need to try it with antibiotics, okay? But we need to maintain that thing and to try to avoid the depletion of the sympathetic activity. But later on, if it's a long time, then what happens is that the autonomous nervous system get exhausted, especially the sympathetic, and then it decreases, and it's the moment in which we need, in order to maintain blood pressure, etc., we need to add dopamine or adrenaline, etc., and the ENI will go very high and the energy very low. This is telling us that, as we saw before, we are arriving to the end. This other study, for instance, and we are approximating to what is happening with the COVID-19 patients. You know that COVID-19, it's a virus that is attacking to the lungs and other organs as well, provoking an inflammation and a fibrosis of the walls, avoiding that the oxygen could go from the lung to the blood and provoking this big hypoxias, etc., and provoking that it's very difficult to ventilate those patients. This is called ARDS syndrome. ARDS syndrome, it's a very dramatic syndrome that, especially in very elderly patients, has a high mortality ratio. And these doctors were already doing a study with heart rate variability, and they were showing that those who has a low total power and a high frequency power, they got higher mortality ratios. Heart rate variability can be used as well to assess which is going to be the result of the weaning in the ventilation. Those with lower heart rate variability were having a more probability of failing the weaning process than those who had a higher. So it can guide you when you can start the weaning process. And this is because heart rate variability is linked to inflammation. This is a meta-analysis that is proving already that interleukin-6 is linked to HF. So what about the COVID-19 patients? Well, you know that we have these two phases, the pro-inflammatory phase and the that is increasing, and when that is happening, then we've got all these problems with the lungs and other organs, etc., and then we arrive to the death of the patient. So taking into account all these ideas that we have seen already published in Hospital de Móstoles, we have conducted a trial that will be published very soon. We have the preliminary results here that I'm going to share with you. This is a very short study. We've got only 14 patients, 7 that survive and 7 that have exitus. And here you have the descriptive statistics. We take into account, obviously, all the ventilation parameters. We take into account the sedatives and the analgesics that they were given. We took the energy values and the ENI values. And we show in the general population that the ROC curve is nearly 1. It's not 1, but it's very nearly 1 in order to detect which patients are going to die and which are going to survive. We saw that an ENI over 80 with an energy below 0.4 was a very well indicator of that patient is going to die. Obviously, the depth of sedation could have influenced these results. So what we did was just to get just the patients with the same RAS score, 4 and 5, so deep sedated patients. And we realized that when we did that, we homogeneized the population, we realized that the results are even better. So a threshold of 80 for ENI has a 100% of sensitivity and 100% of specificity to predict mortality in the following days with 1 in the RAC curve. So excellent results. We saw as well that ENI is correlated to FiO2, which is a very interesting hypothesis to see as well. And there are already some publications showing that heart rate variability is linked to hypoxemia in patients with pulmonary problems. But as well, we saw that ENI is correlated to interleukin 6, as we have seen in the previous meta-analysis. So we saw that energy is correlated to the number of survivals with a very good correlation and a very good area under the curve. So 0.4 means that the patient it doesn't have a good SOFA score and has low probabilities of survival. SOFA is inversely correlated as well to the number of days, obviously, and energy is correlated to SOFA scores. So here we have a possible new indication that we can use in the ICUs. A very high ENA, as you can see here, 100 to 70, with a very low energy, below 0.4, 0.3. The patients have very low probabilities of being alive in the following days. So this takes us into another situation, another idea, which could be the treatment. So probably, and as we have been talking, the autonomous nervous system has been exhausted during this sympathetic activation, and we are arriving to a moment in which we have to supplement this. So could it be possible that a supplement, so avoiding anticholinergics in the early phases will help the patients, obviously adding these catecholamines as well, obviously those antibiotics, etc., which are needed. Could it be useful as well to trying to modulate the vagus nerve? And there are already some ongoing studies with electrical stimulation, for instance. There are some devices that you will put in the vagus and you stimulate them. Could it be possible as well, as in this study that talks about the voluntary activation of the sympathetic nervous system through ventilation, that we could modulate as well this inflammatory and anti-inflammatory response? In this last study that I'm showing to you, which is a very interesting one, these are patients that has been trained into a ventilation process. It's what is called the Wim Hof method, and it's as well with deep in cold water immersions and with specific ventilations. They were training to manage their sympathetic activity, and they went into the ICU of Leiden, and they got LPS intravenous. There were two groups, one that they were not trained and the one that they were trained. So the one that they were trained, and all of them, they got LPS, they were able to manage their sympathetic activity. They were increasing their sympathetic activation. They were looking at the interleukin 6 and their neutrophils, etc., and they were increasing, and they were able to maintain the symptoms of that infections, of that LPS infections, compared to other group that they were not able to. So there is here another door that maybe through ventilation we can modify and modulate the inflammatory response of the autonomous nervous system that could be useful for the patient. So take home message, this is just my last slide, and I cope those 1 hour and a half, all those subjects. ANI is a measure of the autonomous nervous system. ANI is HF-nu, and energy is total power somehow. It will allow you to control surgical stress. You will know which is the balance, the situation of your patient, of the autonomous nervous system, so you will be able to take the right decisions to support your patient and his autonomous nervous system, getting less inflammation response, so better postoperative outcomes, less pain, and less nausea and vomiting, etc. It will help to titrate analgesia in ICU patients as well, as it's been possible to do it during anesthesia, and might be a predictor of mortality and frailty. So thank you very much.